Hi, everyone. Thank you so much for joining us today. My name is Dr. Akilah. I'm a licensed psychologist with the Black Girl Doctor. We are a virtual mental health practice that provides therapy, coaching, and workplace wellness catered to professional Black women. I'm very excited to be here today to partner with the Love Lounge Foundation for this professional development and to have an amazing conversation with these two mental health providers. We have Dr. Dom, who's a licensed psychologist, and Dr. O, who is a board certified psychiatrist. And I'm going to allow both of them to introduce themselves so that you can know a little bit more about why we have these people here today and what you can learn.
Hello, everyone. Like Dr. Akilah mentioned, I'm Dr. Dominique Shaw, licensed psychologist with the Black Girl Doctor. I have a history of interest and training and passion about caregiving, and specifically from the lens of caring for older adults. My interest in working with mothers and people going through the perinatal phase of life really stemmed from my own personal experience of being a mother. And from that, I have sort of paired both sides of the caregiving role and really looked at it from the sandwich generation. And so a lot of my work is around supporting people who identify as being a part of the sandwich generation. And essentially what that is folks who are caring for their children or younger siblings, as well as their ill or aging parent or grandparents. And Dr. Akilah and I recently last fall into the winter into the fall, launched a group for Black women, for Black mothers called the Black Moms Playdate, where we really worked with a group of women to support them, to help them through those early stages of motherhood through the fourth trimester. And so I'm excited to be here to share just what I know of this work and do that with two amazing people.
And my name is Dr. Jennifer Querquill. Most of my patients call me Dr. O. I am a board certified psychiatrist, and I specialize in reproductive psychiatry and integrative women's mental health. A lot of people don't know what reproductive psychiatry is, but basically it's just the intersection of hormonal fluctuation across the life cycle, and how those transitions interface with the presentation or the onset or the development of like any kind of mental health symptoms or challenges. My profession also concerns itself with women's health and how women's health issues specifically intersect with the presentation or development of mental health symptoms. Like Dr. Dom, I kind of came to this work through personal experience as well. And what was so crazy to me is that, I did my adult psychiatry residency. It's like a 4-year training program at Harvard. And it was during my third of my fourth year, I had a baby. And technically I only had 6 weeks of parental leave, but my program allowed me an additional 6 weeks. And they finagled that because they were like, okay, you can do a reading elective where you can stay at home and read at home and stay with your baby. And they made me read about maternal and infant mental health. And so basically I started reading and then I never stopped reading. So over the past 7 years or so, I've just kind of really immersed myself in this specialty. And it's just kind of been a passion that has grown from a personal place of personal connection. I was at the right place at the right time, but it was also so crazy to me that as an adult psychiatrist training at Harvard, I was not exposed to this material. And the only reason I was because I was having this baby and it was this loophole. Fortunately for me, it became my life's passion, but it also just opened my eyes to how underserved women are, how underserved people, pregnancy capable people are in the mental health field, right? This is not part of our bread and butter education as adult psychiatrists. And so as the field of reproductive psychiatry is growing and the perinatal space, I think is getting more and more effort and energy and attention behind it, I feel excited about that. And so I'm really excited to be part of this seminar today and push that mission further.
I love hearing both of y'all's stories, and there's a lot of synergy in this room that a lot of us came to maternal mental health and really caring for women and people who who birth or have babies and families from a space of our own personal experience and seeing that void in the field. I also came to this from my experience during pregnancy, also during my infertility treatments and then pregnancy and postpartum. And I like really felt like there is such a huge need for folks like myself and other people to really be cared for and tended to. And I felt like that was also like something that I just didn't really learn in my own training. And I had to come into that learning and continuing to develop that skill for myself. And also as I began to have more moms, and particularly new moms on my caseload who were coming to me for treatment. So a little bit about myself is I was actually originally trained as a child psychologist. And when I started working with kids, I realized like you have to work with their parents. And so really supporting parents, and now in this phase of life, particularly supporting mothers and moms and people who are early on in that stage of motherhood is really exciting. So I look forward to having this conversation and this seminar with you all. I'd love to frame the conversation just talking about maternal mental health right now and kind of demystifying that. So can y'all share with me, how do you define maternal mental health, and why is it really important specifically for Black women? I'll throw that maybe to Dr. Dom. Let's start out.
Sure. Absolutely. The way I view it is really looking at it from the lens of health and wellness for the birthing mother. And I think and find this really important because what I've noticed is that our society tends to be very focused on the baby. You know, when we think about seeing a pregnant woman, we want to know all the details about this baby. We want to touch on her belly, but really it's just to connect with the baby. And so a lot of the focus, the question, the care is directed towards the baby. And so from this lens of looking at maternal, mental health or health more broadly, it's really shifting that focus back to the mother and the birthing mother specifically. And I really see it important to look at it from many different angles. So physical, emotional, mental, social, environmental, spiritual health, really as this holistic approach to thinking about that care. I find it very important for Black women for many reasons. When we look at the statistics about how we are impacted during this phase of life, we know that Black women are 5 times more likely to die during childbirth. We also know that 46% of those deaths are preventable. And we recognize and know that Black women tend to have higher rates of complications associated with pregnancy and childbirth. And so even more reason to bring this attention and awareness around maternal mental health and maternal health as a whole.
Yeah. So I love that answer. And just to kind of dovetail off that, to me, maternal mental health basically encompasses all of the domains of like health and wellness that surround the perinatal period. And so that's everything that happens before pregnancy, during pregnancy, and after pregnancy. And for me, the moment someone has in their mind that a goal or value of theirs is I want to become a parent, a pregnancy capable person is like, I want to become a parent. That is kind of encompasses to me like the perinatal period, because people can come to me before they're even pregnant and have a preconception consultation. 50% of pregnancies in this country are actually unplanned. And so as a reproductive psychiatrist, I always have my reproductive psychiatrist hat on. And so even if someone's coming to me and they're not even thinking about baby making, I'm like, okay, let's talk about what birth control are you on or not on,
Mhm.
right? Let's talk about the fact that 50% of pregnancies are unplanned, and make sure that whatever medication regimen or treatment strategies that we're putting in place feels okay for the trajectory of your reproductive life, right? And so I always kind of have that hat on. And I love that perinatal mental health encompasses, like I said, before pregnancy, during pregnancy, and after pregnancy. And as Dr. Dom was just saying, there's so many complications that can happen, and Black women are at higher risk for a lot of those things. And I think it's on us to be aware of what those risks are, what those complications look like, because as mental health professionals, we oftentimes see people for a longer duration of time than any of their OBs or maybe even their PCP. And so we can really be instrumental in elevating the quality of care that people have access to. For example, if you have gestation, like I always tell people, pregnancy is kind of like a stress test for your body. It can kind of be a glimpse at what is to come for you down the line, And so if you have something like gestational hypertension or gestational diabetes, right, the OB is going to treat you until that baby comes out. And then maybe 6 weeks after, and then they're like, see ya, and then I'm sure you all know women, we put ourselves last. Everything is family first, baby first. You always put yourself last. And so you don't end up going to your PCP. You don't end up going to see whoever you need to follow up with, right? Because if you just develop something like gestational hypertension, or you develop something like gestational diabetes, you are then at higher risk of developing something like regular diabetes.
Mm.
And oftentimes you don't catch that until much later. And as a mental health professional, having chronic health conditions is a risk factor for worsening mental health, right? Through the inflammatory processes, like having a condition like diabetes can increase the load of something like depression. And so it's important for me to know what your health is during the perinatal period, because again, through your reproductive life, like you exist to be more than just a vessel. Like Dr. Dom was saying, you're more than just a vessel for the baby, right? You are an entire being that deserves to like live your best life before, during, and after pregnancy. And the perinatal period can be such a rich time of information gathering and like a good window into what your life has been and what it will be. And so we have so much skill to bring to the table in terms of helping people, not just during this unique period of time. This might be the window, but it's really going to like open up many opportunities for us to make sure that we're able to take care of our own, and making sure that we're not just focused on, baby, baby, baby. It's like maternal health, right, as well.
That's really important. I really appreciated how you said, that like you see maternal health and maternal mental health as like even before conception, when people are just talking about or not even thinking about the possibility of having children, because there's a lot of maybe unplanned pregnancies. And so it's important to kind of have those conversations. And then you brought up this really important, I think, indication that like a lot of folks see their mental health provider for like longer periods of time than they may think about, or when then they may actually see their medical provider. So then what is our role as mental health providers? So what's your role as a psychologist, Dr. Dom? And then for you, Dr. O, like specifically, what is your role as a psychiatrist in supporting folks in their overall mental and maternal mental health, and also just overall health?
I'll jump in. But yes, just taking pause to name that a lot of my talking points today will be centered around this acknowledgement that all of us are coming in with our knowledge and skill set in mental health more broadly. And here we're going to be really bringing in this consideration, this unique experience and perspective of people who are in this period of life, who are going through these unique experiences. And so as a psychologist, and a mental health provider, therapist, I really see our role as being able to do work to assess and identify the folks that are struggling in this way. If we have a lens as we're meeting with people, again, like Dr. O mentioned, who are thinking about taking on this journey of becoming a parent, if we have a new mom come to our office, or an expecting mother come to our office, that we get to really take pause and ask some questions to really get a sense of where are you in your mental health journey, how much of your experience of being pregnant or being postpartum is having an impact on that. Really having an understanding again about the risk and the heightened rate of mental health conditions for Black women specifically. So another statistic we know is that Black women are 33% more likely to experience a mood or anxiety related disorder than their white counterparts. And so that's really important to acknowledge and to kind of, again, keep in your mindset as you're working with people. I think another major role and part that we have is to really take some time to normalize, validate the women's experience that are coming in to see us, as well as educate, to really talk through these statistics, talk through what we know about what changes happen in the body, because they may not hear this anywhere else. And so this is an important time and space to do that work. And then finally, really taking the lens of treating and intervening in very culturally like competent ways, but also with a level of cultural humility as we kind of sit or kind of are across a screen with a Black woman who is going through these challenges, ultimately with the goal of providing the kind of care that will help them to live happier and healthier lives during this period of time and beyond, similar to what Dr. O was saying.
Mhm.
Yeah, no, I love that. And I totally agree. And I view my work as a reproductive psychiatrist as oriented towards reproductive justice, which is kind of like this stance or like this ethos that we as a community have the right to have kids or not to have children, and to nurture them in like safe and healthy environments, right?
Mm.
So again, that goes back to the education. Like 50% of pregnancies are unplanned, unplanned and desired, right? Or unplanned and not desired. There's a spectrum of where that falls. And I think as healthcare professionals, we have an instrumental role in helping, recognizing the health disparities, right? Recognizing the barriers to reproductive justice, and then think of our role as multifaceted, kind of like two pronged. We have the patient facing role, and then also the
Mm.
provider facing role. I think we're instrumental in helping moms like with the education, understanding what the risks are that we face, being proactive about treatment strategies, recruiting support systems, like all of that patient facing stuff, to make sure that we're able to raise the bar and reduce the risk, right? But then also there's the provider facing responsibility that I think we have. I think we have a lot of leverage with our colleagues, especially as a psychiatrist. If I have a patient who has like experienced trauma, for example, I'm like, all right, you got to let's sign this release of information so I can reach out to your OB. And then I reach out to the OB. I'm like, okay, I'm a psychiatrist working with this patient, our mutual patient. She's working with you. I just want to tell I'm working with her on her PTSD, and she's had this history of like sexual trauma. So some of the upcoming obstetric appointments are causing her a little bit of anxiety. I just wanted to reach out and offer myself as a support. Like there's nice ways to kind of let people know what's going on to
Mhm.
prevent the re-triggering or re-traumatizing of people who have been through a lot. And as a Black woman, it's scary being pregnant. Like all you see are the headlines on TV, like death, doom and gloom, all this stuff, like racism, bias. You're like, where am I safe? Right. And so I even though I can't physically be in all those spaces with my patient, I can insert myself in ways, that make the team know that, yeah, like I have my patient's back. Like I'm in her medical record. I'm advocating for her. I'm providing the education about trauma informed care, about, biases, about things that might cause harm, right? In a way that's obviously gentle and professional, but it's part of that educated like mission that I see as my role again with the provider facing and like the patient facing role. And so yeah, I think that's part of our obligation, like to help elevate the care that our patients receive. Because if you educate one provider, then they then bring that to their
Yeah.
other patients as well. So
It's interesting, and I'm going to butcher this stat right now, but when you were talking about like the patient facing and the provider facing and the education for the provider, somewhere like it was probably in the news, but I read or I saw some stat, and so I have to find it later, about that if there was just like one, I think, Black doctor in some sort of you know what I'm
like,
talking about?
yes, if there's like one Black doctor in a zip code, like then the life expectancy of the Black people in that zip code like increases. I forgot by how much, but I know exactly what you're talking about.
Yes, and it just makes me think, like, if there's just one, you know what I'm saying? And so how powerful it is. I don't know all the reasons for that. I assume that one doctor isn't seeing all of the patients, but I wonder if a part of that is just that one or that doctor's impact in terms of educating other providers. And so I really appreciate like the fact that we can work together to be able to help each other and support our clients, and also the importance of reproductive justice. And sometimes we don't think about that as medical or mental health professionals, but that is very much, I think, a part of our work, particularly when we're thinking about Black mothers and Black parents and Black people who give birth, that there are a lot of complications that may come to that due to racism. Let me ask y'all then, because I have a question from a provider who was curious and like really wanting to know. Um, This person said, I'm concerned that my therapy client is not sharing the full details with their psychiatrist and their medical doctor. What thoughts do you have about this and how I can support honest communication?
Yeah, I think Dr. O already beautifully answered it in so many ways about the role that we can play in terms of getting that ROI signed and making that point of contact with the provider, with the client's, permission to do so. And, I think a deeper conversation about what is interfering, what is getting in the way, what is contributing to that difficulty. So I think, yes, there's that lens and that standpoint of it, and then the direct one-on-one with the client. And so I think one is making sure that the client feels like this is an appropriate and fitting referral. And so, it may be that the client doesn't feel safe or comfortable to be vulnerable, to be open about the challenges that they're experiencing. And so maybe we need to take a step back and position and connect to them with all the Dr. O's of the world. And, I think even deeper than that, really helping the client to explore, like, what does it mean for you to be struggling in this way? And perhaps that has impact on how much they are sharing with their providers. But also beyond that, really looking at what the help-seeking behavior and beliefs are, recognizing that we as people, and especially as Black women, tend to see asking for help as a sign of weakness. And so really clarifying, what are your beliefs about helping or seeking out help and getting that help from other people, but also acknowledging that the healthcare system as a whole does not always feel safe for us. And so that may be a bigger, broader challenge. And again, there maybe finding a better referral where the person may feel more safe and comfortable. I would also really talk to the client about what their goal is. What are they hoping to experience and get out of a, relationship, out of a connection with a psychiatrist, and help them to align their discussion points, what they share or don't share based on what that goal is, as an entryway to developing rapport, as an entryway to building upon a sense of safety to then be able to be more vulnerable or be more open. And then finally, I would maybe even role play what that conversation could look like, really pretending to be the psychiatrist and allowing the client to practice what it felt like to share or ask questions or seek out feedback about what they're dealing with.
Mhm. Really thinking about it's like some cultural factors that you talked about, like this idea of help seeking or maybe being strong, but also it sounds like some like real tangible things that you can do with your client around like role playing, how you can have conversations, because sometimes people may struggle with that. And then I love, Dr. O, when you were sharing earlier about like actually making that connection and making that call with their provider can really go some long ways. I don't know if you have something you want to add to it, Dr. O, before we transition.
Yeah. No, I love that question because it's kind of like framed from the point of view of like the patient or the client and like the therapist, and then who's like I worry that I don't have like the full picture. So as part of, I think, thinking about the structure of your practice, right? Like if when you on board a client or a patient, you have a release of information and you normalize, like, yeah, like I love being on a team with the other people who are supporting you. We support each other in supporting you. So you kind of normalize it. It is normal for us to all have a relationship and we form a team. So I do with every single patient that I have them sign up. Like I have a release of information. I'm like, okay, this is for your therapist. So, and it's kind of like a required form, right? So, I mean, they don't have to fill it out, but like I strongly encourage it. And then I proactively reach out to that therapist and create an open door of communication. So if at any point in time, the therapist or the psychologist has issues or concerns, they can always shoot me an email or we could hop on a call. And it's like normalized, right? That this is a thing. And so you can also bring that language into conversation with the patient as well. Like, okay, like, is this something you would like me to kind of help you communicate to the doctor? So sometimes you can also take on that liaison role, if you're worried about details kind of, being missed. And, sometimes too, as a psychiatrist, if someone's talking to me about something, I just don't always have time to like deep dive. I'm like, oh, have you talked to your therapist about this? Like, is this a topic that, and they're like, oh, I haven't thought about it. So, it's like, you plant the seed, like, oh, maybe this is something that you can certainly bring up. And then, if it continues to be an issue, then I'm like, okay, like, I check in with your therapist every so often, and I might mention that as something that has come up. So I think creating that bi-directional kind of channel or
Mhm.
communication can be really helpful and useful, and just kind of like a safeguard if you really are worried that a patient is not being forthcoming with their treatment providers.
That's a really helpful to do that you're giving us right now. And I want to make sure that we're not missing that. Integrating ROIs, or release of information, at the initiation of treatment, and kind of having that conversation around how you typically like to provide care in connection or collaboration with other providers, and just really normalizing those open lines of communication. So I want to transition us to talking specifically more about perinatal mental health disorders. I know, Dr. Dom, you had shared some stats on that. And so before we get to some more about the actual mental disorders, I was wondering if Dr. O, you can clarify some terms for us to make sure that we're on the same page. You mentioned perinatal, and that being not just like at birth or after birth, but also encompassing the time prior to birth. So, can you just clarify for us what the terms perinatal, prenatal, and postpartum, what do these terms mean, and just the many stages of motherhood and that journey?
Yeah. So they kind of all describe kind of like the spectrum or the arc of time around birth,
Okay.
or around like kind of like the like pregnancy and birth. So perinatal describes everything that happens basically from conception through pregnancy, and typically up to a year postpartum. So if you hear someone describe themselves as a perinatal psychiatrist, they probably cover you from like preconception through, maybe year one, or, a little bit beyond that. Prenatal sometimes is also known as like antenatal. Ante means before. That's another way to describe the same thing. Postpartum, or postnatal, means the time from birth beyond. Typically, it's like a year after birth. But like we all, we're all moms. We all know I'm like 3 years postpartum from my last my last kid. My mom is how old? Like 35 years postpartum from me. So
Okay.
yeah, yeah, it just describes kind of like a period of time from birth. And typically like that vocabulary is like limited to like, okay, maybe the first postpartum year. But as research and studies are coming out, we're seeing more data about how many years postpartum, somebody is. And so, yeah, those descriptors just kind of anchor you to kind of give you a frame of reference when talking to other like patients or clinicians, where somebody kind of falls along that spectrum.
Do you mind just speaking to that for a moment here? Like, what is the research saying now about like how long that postpartum period is, the recovery period?
So what do you mean by recovery? Like,
That's a good question.
do you ever
Will we
recover?
ever? I don't know, because I'm 2.5 years down, and I'm like, like just think of like your physical body, maybe, and your like mental, emotional, like about how long. And I realize that might be relative, because people might feel like they're recovering for very long periods of time, and I give that weight. But what is the research saying about right now?
Yeah, so I mean, I was joking when I said, "What do you mean by recover?" But like you fundamentally change. Like your biology changes as a result of experiencing a pregnancy. And so, I'll talk about this, maybe a little later. But there are some studies that have gone out at least 6 years postpartum that show that some of the brain changes that moms or like pregnancy capable people have experienced as a result of going through pregnancy persist, that long. And that's because you are a changed person. So when people talk about snapping back and all that stuff, I'm like, maybe I don't know what it is. It's not snapping back, because you're not the same person that you were before, before you gave birth. There's different ways to measure
Mhm.
recovery, right? Sometimes people talk about emotionally, how long does it take you to feel like yourself, or to feel like level again? Sometimes
Mhm.
talk about recovery in terms of like their career ambition. That's something that comes up a lot. Some people talk about physical recovery, and those things are often it's very very personal, right? It depends on what was your health before the baby arrived, and like in terms of like some physical elements, hormonally speaking, are you breastfeeding? Are you lactating? Because that is also hormonal change that might, cause some changes that might persist versus someone who like stopped breastfeeding earlier or chose not to breastfeed at all. So it can be quite different. Sometimes people say first postpartum year because like some of the like biological elements tend to settle out by then, but it's you change, your body changes, like everything's changed postpartum.
Yes. What I'm kind of taking from that, thinking about my therapy lens is to really remind people who, parents and folks who are postpartum, that it's not like a quick, recovery or snapback in any of these ways. Like, I think the 6 weeks that we might get for some folks, if they are, get 6 weeks of recovery, like that's just like a drop in the barrel of how long it takes many people to kind of be able to resume life in a way that feels some like of a semblance of kind of who they are, with the understanding that there are things about you that do fundamentally change in terms of your physical recovery and other types of recovery. And I've recently seen some data or research talking about just like the career and financial recovery for folks who have birth and how it dips for years after that. And so I appreciate you even bringing up the career aspect and the financial aspect, because that also, I think, is a part of people's overall health and a big part of the picture.
That's one of the things that I just kind of like love so much about this field, right? It's not just the biological elements or the psychological elements. There's so much you need to understand about like the social dynamics that change, like the relational dynamics that change, the political landscape, like how this person is going to be moving through the world so differently. So it's such a rich time of transition that's beyond the psychology, that's beyond the biology. It's like, how is this person now moving through the world like differently? And I love the intellectual challenge of kind of like marrying all those pieces together. And I think you kind of highlighted that.
I think that's so important here. And I think that that's what a lot of people like come into our offices dealing with, but may not be like, I don't know that our society does a good job of always bringing that to the forefront. One thing I think then brings that's coming up is like myths. So can you talk to me about like what are some myths about the perinatal mental health, and what are some barriers to treatment for Black women? Dr. Dom, do you want to start us off?
Sure. I mean, y'all are already naming quite a few. The snapback is definitely a myth. I think and understand that even beyond that, and some of, the things that complicate the mental health experience for women is this idea that we at times sort of glorify and idealize motherhood in ways that are true, but in ways that are not fully true. That this period of life, this new role, this new identity is hard. Yet society tends to overemphasize how positive it is, how happy we should be, how joyful it is to bring new life into the world. Again, all things that are true, while missing a big other element of the picture. And so when we hyper focus on the positivity, or we focus on the toxic positivity, it can lead to women experiencing negative thoughts, such as, because I'm not happy, I must be a bad mom, and fears of, if I'm not doing this well, if I'm not happy in this, if I'm seen as being a bad mom, somebody might try to take the baby away from me. And so again, those are some of the roots to the mental health issues that people are dealing with and that they're coming into therapy with oftentimes. And then when you think about focusing on working with Black women, it then gets layered in with the strong Black woman or superhero syndrome that leads to these extreme, unrealistic expectations, unhealthy expectations around how we should be carrying this role, how we should be approaching this new identity, being able to handle it all without asking for support. All of these things really carrying a heavier weight for this process, for this experience. And so, again, going back to this like hyper positivity playing a big role in the myths that people navigate through as they're going through this phase of life. From the standpoint of barriers, I'll name just a few. So we've talked a little in terms of racial trauma within the healthcare system and how that can create distrust that we bring into, working with our OB, working with a psychiatrist, working with a therapist. Those things, that distrust can inhibit our abilities to seek out and ask for help. Insurance is another major barrier. Resources is another major barrier for Black folks. But it's a large list. Those are just naming a couple.
I will say, like, from a psychiatrist perspective, I'll probably, mention like two myths. Like, one myth is that medications change who you are.
Mm.
That's a big fear that people often come to me with. They're having symptoms and they're like, oh, but I don't want to get addicted to the medication. I feel like it's going to change who I am. And I'm like, you know what changes who you are? Depression changes who you are. Are you living your best life now with this depression? Like, I describe it kind of like as an Instagram filter, right? Your whole world is filtered through black and white. That is not you living your best life. Depression changes who you are. Crippling anxiety changes who you are. OCD that's uncontrolled changes who you are. Psychosis changes, all of those things change who you are. If you are not living your life in accordance with the values you have set out for yourself and you're not achieving your goals, that is changing who you are.
Mhm.
Medications can help clear that field, right? So that's myth number one. Myth number two is that for folks who are on medication and they're preconception, right? They're thinking about pregnancy or they are pregnant. Sometimes people think, oh, the safest thing for me to do is to stop my medications because I'm pregnant now. That is also a myth. There are very few medications that are actually contraindicated or like not advised during pregnancy, like mental health medications. So it is important that you have the guidance of a perinatal or reproductive psychiatrist to help you think about your medications. I love, love, love doing preconception consultations because that kind of gives us the gift of time to really optimize treatment strategies. Think about, the longevity of a treatment plan. But it is what it is. If you pop up one day, you're like, doctor, oh, I'm pregnant. I'm on these meds. We work with it, right? We evaluate from there, and we meet you where you are, right? And a lot of what I do is counsel people on risk. So yes, I tell people there's no such thing as a free lunch during pregnancy. You could eat a sandwich and have an allergic reaction, and then that is a risk, right? You could take Tylenol and have a reaction. That is a risk. Yes, there are risks to psychiatric medicine, but there are also risks to undertreated psychiatric illness during pregnancy. And so a big myth is that not taking my medication is the safest thing to do. That is not necessarily true. And so what I sit down with people and I talk to them about is what are the risks of taking the medication and how does that compare to the risk of not taking medication? What are your goals and your values and how do we make sense of those two risk profiles and how do we strategically choose small risk to mitigate big risk? So that's a lot of what I do. And so I would say a take home point is like, if you ever have a patient that's like, I stopped all my medication, like maybe have a conversation with her, about that. Or if somebody goes to an OB who's like changing up all their medications because they're pregnant, be like, oh, maybe you should talk to a reproductive psychiatrist because that's also not necessarily the safest thing to do, and so just you kind of having those nuggets in the back of your mind and like you hear patients talking about those red flags, like those myths, you can kind of steer them like, oh, maybe that's not the best, maybe we can get a second opinion here and like have someone who does this all day and night, like walk you through what this would look like. So those are the two myths that I would say.
I really appreciate you speaking to this, particularly the myth that the safest thing is to not take medication during pregnancy, because that's something that I think a lot of therapists kind of get a lot, and who work with people who are pregnant or are moms or moms to be. We actually have a question about that. So I think maybe it makes sense to kind of ask you, and you're speaking to it already, but a provider asked, what do you recommend for a therapy client who is diagnosed with postpartum depression or anxiety, and they're expressing fear or concern about taking the medication that they're prescribed for this?
Yeah.
What do you say?
Yeah. So before I get into like the nitty gritty of like the medication, I kind of take a step back, right? And I'm like, I totally empathize with your fear. That is your mama bear instinct kicking in. You want to do what's best for you, for your family, for your baby. And I say, let's carry that energy with us throughout. One of the reasons I get so passionate about this work is that I'm sure many in the audience are familiar with that transgenerational passing down of trauma, or that that transgenerational passing down of symptoms. One of the reasons I feel so passionate about the perinatal work is that it is a time of high impact to break toxic cycles.
Oh.
It is a time of high impact to break toxic cycles. You inherit the trauma from your mom, you inherit the symptoms, the stress, the depression, the anxiety. You inherit that all from what your mom went through, what your grandma went through. And so the more we are able to keep Black women feeling good and healthy and strong and capable before pregnancy, during pregnancy, and after pregnancy will impact the health of her future children. And so one of the reasons I say, I want my moms to feel good before pregnancy, i.e. Preconception, during pregnancy, is because there's something called the HPA axis. That is, it's basically a circuitry basically in your stress response system, basically, just to keep things simple. Your baby's stress response system is developing during pregnancy. The metaphor I use is that we don't want to season your baby's brain with stress, because then it's going to absorb all the stress and become highly sensitized to stress. So if mom is going through a lot of trauma, a lot of depression, a lot of anxiety, a lot of just bad things happening to her, her baby's brain is forming and becoming highly sensitized to stress, becoming specialized in thinking this world is a dangerous place. I need to be able to detect threat and trauma and things like that very, very easily. It's almost like overreacting to situations. So then those babies, when they are born later down the line, are at higher risk for developing anxiety, at higher risk for developing depression or other sort of behavioral health or cognitive issues, themselves. So that's why during pregnancy, it's important that you keep yourself as stress-free as you can. Right? You are managing your stress. You are managing your mental health symptoms. You are managing your depression, because all of those things have impact on your pregnancy. Right? They also, they have, there's many risks, right? For example, anxiety can increase your risk of things like gestational hypertension. Gestational depression can increase your risk of gestational diabetes. All of untreated psychiatric illness can put you at higher risk for things like preterm labor, placental abruption. There's all sorts of obstetric complications that can be associated with having undertreated or untreated psychiatric illness. So you just not taking medication or doing anything to take care of yourself during pregnancy is not free lunch, right? And so again, making sure that you feel good during pregnancy. And then postpartum. So your brain doubles in size between age 0 and 12 months. But there's still a really rapid period of growth between age 0 and 3, right? Your baby's brain is so sensitive to the environment in which it's brought into. So if you have depression or if you have anxiety, your baby is going to have some genetic predisposition. Just because you have, you carry those genetic ingredients, you probably pass them down to your kids, right? But just because you have a genetic predisposition doesn't mean you're going to develop the illness. It is a combination of nature plus nurture. So this is where the nurture part comes in, right? So postpartum, there's a ton of psychiatric and pediatric literature that talks about postpartum depression or postpartum illness having an impact on that baby's development down the line. And so this is not about love at all, right? Love is not part of this equation. But if mom is preoccupied with anxiety, having racing thoughts, really depressed, really struggling to pull herself out of bed, it's a task to take care of the baby is not getting the full benefit of all the social, emotional, kind of cultural, cognitive, learning opportunities that you get from blowing raspberries in their belly and making eye contact and doing the oohs and the ahs and all the, the silly mom stuff. You think it's silly mom stuff, but those are really the fundamental nuggets of learning, of the socialization, of reciprocity and all those things. And so there's so many studies that show that kids who are born into households where their primary caregivers are struggling with their mental health go on at higher rates to develop mental health symptoms themselves down the line. So again, it's this transgenerational passing down. There's multiple mechanisms at play here through the transgenerational passing down of symptoms through easy crossing of stress hormones to the placenta to the environment in which the baby is kind of brought into. Yeah.
Wow. Dr. O, what I'm taking away is it may be the loving thing to do, because I think this is really about like loving and caring for your child when when parents are making these decisions around medication. And the loving thing to do for your child and for yourself may be taking the medication because that may prevent other sort of disorders or things that really do have a huge effect on the parent and the child.
Yeah. Yeah, no, I think that's wonderful. And like, there's medication is but one treatment strategy. There is a number of things that you can do to take care of your mental health. As a psychiatrist, everyone doesn't leave my office with a prescription, right? They
Mhm.
leave my office with an understanding, right?
Mhm.
They leave my office with options. And so depending on how severe people's symptoms are, if someone's symptoms are like mild to moderate, sometimes I'm like, yeah, psychotherapy might be a really great way to like kind of get you feeling better. Let's try, let's try that for like a solid like 12 weeks and see where your symptoms are. In addition to like other lifestyle or behavioral modifications, making sure that your sleep is on point, that you have all your social supports, in a row. Sometimes if somebody is coming with like more severe symptoms, I'm like, okay, maybe a medication would good initial treatment strategy while we are layering on the therapy and like the other interventions. And so it's not always meds. It's like where do meds fit into the spectrum of treatment? Where are your symptoms, right now? That's kind of how we find like the treatment plan. And so taking medication can certainly be part of that. And when I talk to people about meds, I do talk to them about, like I said, the risks of taking medication because it's not a free lunch. But like I said, we got to be strategic. We choose small risks to avoid bigger risks.
Dr. Dom, I want to transition to you. Can you tell us a bit about like what are some of the common perinatal disorders and what are the rates of these disorders for Black women specifically?
Yeah, yeah. We don't have great numbers specific for Black women, so I will
Okay.
speak mostly from the lens of just the general, non-specific rates and information that we do have. A lot of the statistics I'll offer here is from the Perinatal Support International website. It's a really great resource that we'll talk a little bit more about at the end. But I'll start by just talking about baby blues, which is a very specific postpartum disorder or condition that people experience. And so that is oftentimes due to the shifting of hormones that happen in that very early postpartum window of time. So it typically happens like right as we're leaving the hospital, which is the least, ideal time for this to all happen, up until anywhere from 10 days or a little longer after delivering the baby. It's a period where people feel a lot of depression, a lot of sense of anxiety, a lot of crying may happen, difficulty making decisions. I can speak for myself personally. I was one of those folks who dealt with the baby blues. It came literally out of nowhere. As a mental health provider, was not really fully grounded in myself and my knowledge and my skill set to even be able to handle it effectively. And so it just speaks to how impacting it can be. It is also very common. So I was seeing statistics anywhere between 80 to 90% of women experiencing this. And then we transition into some of the other mood and anxiety disorders. And so what we know, kind of the big statistic that we know is that 1 in 5 women experience a perinatal mood or anxiety disorder. And then when we begin to break things down, we know that anywhere between 15 and 21% of women deal with depression. And again, when we look at these specific diagnoses, we want to be mindful, using the DSM to really think of this from the stance that these symptoms, these experiences are causing impairment in some part of the person's life. And so very important to think of it from that perspective. So again, 15 to 21% experiencing depression, anywhere between 6 and 10% experiencing anxiety or a panic disorder, anywhere from 3 to 5% experiencing OCD and all of its related symptoms, an average of around 9% for PTSD, and then 1.1 to 0.2% for bipolar disorder and postpartum psychosis. So that's just like the nitty gritty rundown of all of those
Yeah.
disorders.
Can you tell us a little bit, like, when we're thinking about like postpartum anxiety or prevention, or anxiety or depression, like what specifically might we be looking for that may be different from someone who's sort of not, who's outside of that postpartum period? So anything specific to moms or to people who just have given birth in that short period after that, or the year after that?
Right. Or 6, according to
Right.
now, so it's giving me some insight about my own experience. But again, kind of really being mindful that we all, as mental health providers, have hopefully a strong understanding of the DSM and all of the symptoms related to depression and or anxiety or all the other types of anxiety. And so really when we are thinking about the person that's coming into the room who is in this period of life, some of the considerations to take on or to think through are the various types of risk factors that may increase their likelihood of experiencing a mood or anxiety disorder during the perinatal period. So one major risk factor is a prior history. So if someone has had an episode of depression, had a history of anxiety, chances are that it will, either be exacerbated or resurface during their prenatal or perinatal period. And then the way the risk factors break down, and I'll name just a few, fall in this biopsychosocial category. So biologically, some of the risk factors are for all women, just the intense hormonal changes that happen. And so we want to be mindful of what that looks like for that specific person. Another biological factor would be having multiple, if it's a pregnancy with multiples, that just changes the body in unique ways. That can be an additional risk factor. Really, from the psychological lens, thinking about this period of time being an intense transition. And so if folks have difficulty adjusting to change and transitions, that could be a risk factor. Things such as a NICU stay, infertility, or fertility treatments prior to getting pregnant can be a risk factor. Any types of birth trauma centered around the birthing process and or postpartum during that period of hospital stay. And then any of the complications that happen both physically but also emotionally during that postpartum period. Socially, some of the risk factors include a lower socioeconomic status or lower access to resources, any relationship stress that is present, whether it be with the partner or other family members or other people around in the environment, and then kind of dovetailing on that, just a general lack of support for some of the practical and emotional needs that a person would have.
Awesome. Thank you so much, both of you, for this important information about perinatal mood or mental health disorders. I want to move us on to talking about like assessment and treatment. So we know about kind of what's going on. How do we assess this? Like, what tools do you recommend, and when should screening occur? I want to ask that to Dr. O.
Yeah, so again, we're thinking about the spectrum of care, like where you are interfacing with the patient. I think you always have your screening lens on, you always have your screening hat on, because perinatal depression can occur anytime when the person is pregnant. Another risk factor, depression during pregnancy is a risk factor for postpartum depression. So if you notice your patient is pregnant and they're struggling with their mood, right, you might want to think about screening tools, right? Screening for something like postpartum depression. For myself, as someone who prescribes medication, I might use my screening tools to kind of help me track the progress of how any kind of intervention that we have put in place is working.
Mhm.
So, if I start a medication, we might do some screening beforehand. When I'm doing my kind of like diagnostic evaluation, I might get some baseline levels, like some baseline screenings using things like the EPDS, the Edinburgh Depression. I even forgot what it's called. I always just call it the EPDS. Yeah. And then there's the PASS, the perinatal anxiety screening scale, as well. Those are two tools I use a lot, but I also layer in the like GAD-7 and PHQ-9. Those are more general depression and anxiety screening. The ones that are perinatal specific take account some of the physical ways that pregnancy can be taxing, right? Because, when you're pregnant, you can be tired all day, every day. And like being tired all day, every day to a non-pregnant person could be a symptom of fatigue and like depression. But to a pregnant person, that's just Tuesday, right? So it kind of takes into account some of the physical ways that pregnancy can be like just a bit of a slog. And so using those screening tools, I use them throughout the course of treatment just to kind of help measure how my patient is doing. Sometimes people use these screening tools in like primary care settings, and then for them, those are triggers for referral. So if you have like very severe scores or somebody indicates like suicidality or something like that, that is then it triggers like, oh, this person needs a little bit of a higher level of care. So there's different ways to implement the screening tools, whether you're using them to like connect someone to care or using them to track progress. I think a good rule of thumb is, each screening tool can be used differently, but I think 2 to 4 weeks is like a good window of time to consider rescreening.
Mhm.
Depending on what's going on, but sometimes once a trimester can be useful. You don't want to do it too close together, because then it's like, what are you actually capturing or what are you measuring? But if there's some sort of intervention that you've put in place, or some sort of like material change that you want to track, doing that can also be useful and helpful.
Now, so you gave us some screening tools and some things to look out for, Dr. Dom. You gave us some symptoms and some stats on how often these things might occur. What do we do? So can you describe your treatment approach and your recommendations for providers? I'm going to let Dr. Dom start us out, and then Dr. O, you can finish up.
Yeah. Like I said before, really see my role as being the voice of reason at times, being able to really normalize, destigmatize, validate the person's experience. And, through that and with that emphasis, doing a solid assessment. I think in my experience, when I went in for like all my postnatal care or postpartum care, it was always the PHQ-9. And I was always like, ugh, just annoyed because like PHQ-9 is great, but it didn't really um, pick up on some of the things I was experiencing. And another bit of research that we know is that Black women tend to not overreport, but emphasize somatic symptoms, and the PHQ-9 tends to have a lot of those symptoms there. And so again, to Dr. O's point, I'm tired all the time. Yes, and whatever the highest rating is, 3 for that. But was that really capturing the, other parts of the symptoms that I was experiencing? And so doing something like the EPDS can help to remove some of those somatic symptoms and get down to more of the meat of the symptoms that people might be experiencing. In my work, I really work hard to build a strong rapport with clients. Really, again, therapy can be a very vulnerable space where people show up in ways that are different and unique to how they're showing up in other parts of the world. And so I want to create a very trusting, safe environment to do that in. Ultimate goal is to mirror that experience to how they can show up outside of the therapy room. And so specific in terms of interventions and approaches that I take to the work, I tend to use more of like a CBT and or ACT approach, acceptance and commitment therapy approach. CBT has been researched and supported as an effective treatment for perinatal, postnatal care for people dealing with mood and anxiety disorders. Some of the other approaches that have been supported include interpersonal psychotherapy, peer support, group-based therapy, as well as psychopharm. And so, really tailoring it to the person that's entering into the room. Some people like individual therapy, some people prefer group, some people want to do therapy and medication. It's really being aware and mindful of all the different tools that we have available to us and centering that with the person that we're working with.
Dr. O?
Yeah. So, in terms of assessment and treatment, as a psychiatrist, I go through a thorough like diagnostic evaluation. Like Dr. Dom was saying, like this conversation already presupposes that you kind of know how to do all that, right? But then when you come to that diagnosis, then with my patients, I work through a treatment plan, right? And I always tell people a treatment plan, it's like a living, breathing like document, right? It's flexible and we respond to how you respond. And we're always revising and we're always changing. Things that work well, we're going to double down on that. And things that don't no longer suit you or they're not working or they don't really work for your lifestyle, there's no point in like continuing to like harp on things that are just not going to be a good fit for you. So my treatment plans generally have like five pillars, right? There's the medication piece where we talk about medication, and that's all the education around the medication, the choice of the medication, thinking about what are the side effects? Like, how do we respond to side effects? How do we think about dosing? Like, what's our exit strategy here? Like, thinking about all of the like medication pieces. Sometimes I also talk about supplements. Supplements sometimes can be a useful place for people who feel a little like hesitant about medications to start, depending on the severity of their symptoms and how appropriate that would be. But it is a treatment tool. Sometimes it can also be useful adjunct treatment strategies for like a medication treatment plan. I always talk to my patients about psychotherapy, whether that they're doing that with me or that we're trying to find them like referrals, people who are specialized in like the perinatal period or specialized in infertility or specialized in pregnancy loss or specialized in miscarriage or specialized in like the parental transition, like those early toddler years, they can be really something. And so there are people who kind of specialize in those, where you are on like the reproductive life cycle. I kind of do a lifestyle and behavioral audit as well, because like I said, it's not all meds. There are, I always make sure with my patients that your day-to-day behaviors, the habits that you have, right? The day-to-day choices that you're making are not mistakenly undermining what you are trying to accomplish through psychotherapy with supplements, with medication. Mm-hmm. So we make sure all of those things work together in harmony. These are things like looking at your diet, right? If you're not getting the right nutrients, your medication is not going to work. Right? Your medication needs the right ingredients to help your brain make the feel-good chemicals. If your sleep is erratic, you're not going to get better, right? So I make sure that we have like a good sleep plan in place. Those are skills that we can teach pre-conception, emphasize during pregnancy, and then think about sleep plans postpartum, because poor sleep, again, is a risk factor for the development or worsening or exacerbation of underlying psychiatric, illness. So counseling parents to be about what does sleep look like with a baby? Who's going to support you overnight with the babies, right? So I have a whole spiel about postpartum sleep, and that's so important. We think about are you exercising? Are you getting sunlight? Like, who are your support systems, right? Who's putting your laundry away? We talk about the granular things about postpartum, because all the the world doesn't stop just because you had a baby, right? Right. You still got to do all the adulting things that are stressful, regularly stressful. And then you got a newborn on top of that. So we strategize and we think about creative ways to kind of let your life not come to like a screeching halt just because you brought a baby into the world. Right. And then sometimes we have to get creative around the tools and the accesses and the resources that we have access to, because not everybody's partnered. Right. Sometimes people, might be a single mom by choice, like, whatever your situation is. It's like, how do we then recruit you an ecosystem of people who can support you? Is there a church community that you're part of? Is there another single mom who you can like trade off nights with, or like have some sort of like support? And when we have the gift of time, I can't emphasize this enough, the gift of time really sets us up for success. When we think about these things beforehand, it's not when the house is on fire that we're like, oh, like, did we buy a fire extinguisher? It's like, no, you get that beforehand, right? You fireproof everything beforehand. So before everything like kind of blows up, we like get all the protective things in place. And then lastly, part of why I love this work so much is that it's a lot of teaching. There's a lot of psychoeducation, a lot of, like Dr. Dom said, a lot of normalizing, right? There's so much that is undiscussed in the transition to motherhood. There's something called matrescence. Matrescence is the transition to motherhood. And the same with the adolescence is a transition from childhood to adulthood. It is a fundamental transition. It's a biological transition. It's a psychological transition. It's a social transition. With adolescence, you kind of have that, you have like sex ed at school. Everybody's talking about it. You're like, oh, you're going to have like growing pains and BO, and you're going to have to wear deodorant, and like, you're going to have feelings for people. And like, there's a cultural conversations, but we don't have a similar such conversation around the transition to motherhood. It is all commercially focused. It's all like, buy this, buy that for baby, right? It's not like, mom, this is how your life is going to change. How do we prepare you for that? So I do a lot of that kind of psychoeducation piece. I love bringing in external resources, whether that's books or podcasts or articles, whatever it might be, a workbook. that really starts to like plant seeds and like normalize and give people kind of like the arc of like, okay, this is kind of like in the realm of what you can expect. Especially for my professional moms, I talk to them about the work parent transition. I'm like, this is
Yeah.
it is something, right? Yeah, like being a professional, like working inside the home, working just like being a stay-at-home mom, that is work, right? And then that's
Yes.
full time. It is a full-time hustle.
Over full time, man.
Like I'm in California right now working in a psychiatric emergency room and I'm hustling at work, but I'm like, oh my, like I have a few days off for my kids. Like it's a lot, right? It is a 24-hour situation, you know, where you are on and your mom all the time, you know? And so I talk to my patients about these different developmental transitions and milestones across like the parenting spectrum. And so the more you can educate yourself about the transition and the richness of that transition, the more resources and tools that you are aware of, the more robust your resource library is, the more value you kind of bring to each of your patients or your clients.
Y'all both gave a lot of really valuable stuff. And I really appreciate you sharing matrescence and like just the terminology around that transition. Before we move on, I just want to ask you, like, can you briefly, Dr. O, talk about how do you take into account like brain and physical changes during the perinatal period as you're providing assessment and treatment? And can you speak? I assume some of the things you talked about connected those things, but can you just make that connection for us between the brain changes, the physical changes, and then what do you do with folks for assessment and treatment?
Yeah, yeah. So I feel like the brain changes are just more important to kind of understand how profound the transition to parenthood is,
Mhm.
right? They have done studies where they have taken MRIs of people's brains before they got pregnant and then after they got pregnant. And you can tell the one that's the pregnancy brain. That's how profound like the brain changes are. The brain changes are mostly changes in like, you know, gray matter in the brain. There's like shrinkage of the gray matter. And then also a little bit of shrinkage, like loss of volume of the hippocampus. So the hippocampus is oftentimes responsible for a lot of like learning and like memory. And then gray matter, like the networks in the gray matter oftentimes can be responsible for, how do I say this? It's like preparing you to think about the needs of another person in a really intense way. You know, I
Mhm.
joke with a lot of my patients. I'm like, you know, anxiety is it's I tell my patients anxiety is a gift. We never want it to completely go away, right? Because people who don't have any anxiety, they don't live very long because they just do things that are dangerous and then, you know, it's kind of game over, right? But anxiety helps you to think ahead. It's a very future oriented condition, right? Helps
Mhm.
you to think ahead, to plan ahead, to weigh risk, right? And so I tell my patients, you know, now you have anxiety for two people because your little baby doesn't have any skills, right? They don't have any way to protect themselves from any sort of like danger or threat. And so you have to think, okay, if there's a lion coming, I got to get myself to danger, but I also got to think about my baby, right? Let me think about how I get my baby to safety as well. And so some of the changes in the gray matter are really focused on intuiting the emotional state or the needs of another person. It's focused on optimizing attachment. It's focused on the bonding between mom and baby. And those are the changes that if we do an MRI 6 years postpartum, like some of those structural changes in the brain still persist. The
Mhm.
hippocampal volume loss that kind of recovers, at least I think around 2 years postpartum. But I always tell this to my moms because it's not that you get dumber, right? You're not getting dumber. This is not about the loss of IQ points. Just from an evolutionary standpoint, and it's like ensuring the survival of your species, right? Your brain has decided, okay, this is the most important thing. So it will be really annoying when you go into the kitchen and you're like, why did I come here? Like, you know, that's what like kind of like mom brain is. Like your brain has now decided going to the kitchen to like get the milk or whatever is like not the most important thing. It's like thinking about how do you ensure the survival of your kid. So your brain becomes very specialized. It's an adaptation. It's an advantageous adaptation that allows the survival of our species, that the parenthood networks that kind of get really strengthened. And I think they basically persist. You know, like once you're a parent, you're kind of, you know, it's just kind of your brain changes like kind of in a permanent way.
Mhm. That's really powerful education, and I think really important for parents to know. I want to move us on to talking about family and social support. You already started to talk about this in how you provide services and care to your clients. So, Dr. Dom, I want to throw this one to you. Can you tell us, like, how do you include families and partners in your work with your clients, and include any support that you might provide to the non-birthing parents? And this is like a big one, so I'll just kind of give you the umbrella and let you go for whatever you want to go for. The other piece is like romantic relationships sometimes suffer following the birth of a child. And so, like, what type of attention do you also give that in therapy with moms, with fathers, with parents, with non-birthing parents? Like, how do you manage all of those things?
Yeah, I know this is such a critical topic. We talk a lot about the village and the role that the village can play, and oftentimes it's thought of like taking care of the baby, but the village is also there to take care of the mom and the birthing mother. It doesn't always play out that way, but that's the ideal. I think what I'm hearing of parts of your question, one, in terms of the non-birthing parent, that there's been some research to say that 1 in 10 experience depression within that first year postpartum. And so that speaks to the impact of, again, this life change, this taking on a new responsibility, that with that can come some, experiences of depression. I think it is important to bring that topic into the work of therapy, really taking pause to check in with the client about, what's the state of your relationships, across the board, but specifically, if you are partnered, if there is a non-birthing parent around, what's that dynamic like? Is there support available to you in that relationship? How satisfied are you with that? Really getting a better sense and assessment of what home is like. And based on that, using that information to then decide, is there room or need for making referrals for that non-birthing parent to seek out their own mental health treatment? Giving referrals for support groups for non-birthing parents to help them along their journey of transitioning to this new role. Sometimes I'll even bring that person into the therapy space with lots of caution and lots of, clarity about what my role is, what their role is, what this means in terms of therapy. But just like a one-off or a two-off of a joint session to collectively all three people or more in the relationship come together to talk about, what has been challenging? How can you better support one another? What are your needs? Really creating a safe environment to name all of that, and then put some attention around how can we grow? How can we better, impact the relationship overall? And then when I think about relationships outside of maybe, the direct household, it's so important for mothers, for people going through this period of life to have support, to have access to this village. And I think we've talked about this in different ways, but to really take a step back and recognize who is available, who are your people, where are the gaps, how can you work to fill those gaps, and really thinking about how that work is hard, to be able to get out and even to be able to be on a phone and have an adult conversation with someone else can be hard. There are lots of barriers to that, both getting out and doing that at home. So like childcare can be a big barrier, having somebody to just hold the baby while you're doing something outside of caring for the baby. Sleep issues can be a big barrier. If we're not sleeping, we're not wanting to put ourselves together to then show up in a relationship. And so that can be a huge issue. There oftentimes are a lot of changes in relationships, even from the standpoint of friendships, when we take on this new role, where it can create some distance or tension. And the way I think about those barriers is to work to modify what is modifiable. So some of those things are modifiable. So we can do some problem solving to think about, like, can grandma come over to watch the baby while you go out and hang out with the girlfriends? Or, can your partner step in and take care of the baby, or, take over night shifts so that you have a little sleep to then be able to socialize and meet that need. And so really putting some emphasis and focus on that. I also have found from my own personal experience, trying to pair activities, so all the mommy and me stuff, as a way to build that network of friendships, of community, with other women who are going through a similar life change. That's also another space for peer groups, support groups. Just to put a little plug for the Black Moms Playdate, that was really our whole, motivation and guide, was to be able to create an environment where people could build upon that. And then, even when we parent and we bring baby along, that's one thing, but we do desperately have a need for time and space alone. And so really figuring out ways, problem solving, how to carve out opportunities for that, whether it's delegating responsibilities, creating a schedule to where that is a predictable routine that is a part of you and your baby's and your family's routine. Again, really just being mindful of how important that alone, quiet, still time is.
Thank you. Dr. O, is there anything you would add to that in terms of how you engage social supports and folks who are the non-birthing parent in treatment?
Yeah. So there's a couple ways. Again, going back to that psychoeducation, I think there's a couple of books that I oftentimes recommend that people get or read. I think I can share the resources with you, like
Mhm.
after, just to kind of give
Yeah.
some titles. But that, like, one of them is called, what's it called? It's by Molly Millwood. It's called Marriage. I think it's like Marriage and Motherhood, something like that. But basically, it talks about how your relationships change and how the quality of relationships dip down. I want to say it's like a couple years in the beginning. It talks about, like, how some gender roles kind of emerge and how, like, fair play is, like, oftentimes a good one by I'm forgetting her name, Eve Radowski, something like that. I'll again share the link. But she talks about how, like, the division of labor in families, like the way that our society is set up, like moms oftentimes become the default parent who knows all the things and does all the things for baby, and that can lead to a lot of feelings of, like, overwhelm. So having upfront conversations with the family structure, with, like, the dyad, right, about what is the division of labor going to look like when baby arrives, right? Sometimes having intentional conversations before kind of like default modes of operating just kind of kick in. And then, mom ends up feeling super overwhelmed because she does all the things all the time. Um, Other things like sleep, like Dr. Dom said, is very important. So I oftentimes bring the partners in and we have conversations around sleep. I tell people the average adult needs about 7 to 9 hours to feel, like, refreshed. You do know, like, refreshed. But postpartum, it's hard when you're trying to establish your feeding supply, or you're, like, waking up your milk supply, you're trying to, like, feed baby. Like, initially babies, they're not compatible with sleep. They wake up a lot, maybe every 2 to 3 hours to begin with. So you're operating from a place of sleep deprivation. And again, that strong Black women do all the things all the time. You kind of put yourself into, it's not sustainable, right? It's not sustainable to be, like, waking up like that. So I often talk to my parents, or the mom, and, like, the support system that she has around her. How do we set up a good system around sleep X
Mhm.
number of weeks postpartum? I try to get my mom's 4 to 6 hours of consecutive sleep in a row, because having 10 hours of sleep in 2 hour chunks is not good for your brain as 4 consolidated hours
Mhm.
of sleep. So I talk about, what is the sleeping arrangement? How do we, I tell my mom, those brain changes that I talked about, it makes mom transform into Spider-Man. So, like, if a baby is, like, squeaks or, like, has a little bit of gap, you, like, wake up from sleep and you're like, oh, is my baby okay? Right? You're so sensitive to every piece of stimuli that comes from your baby. So I'm like, do you need to remove yourself from the room where baby is in order for you to get solid sleep? Right? I talk about feeding plans. Like, are you breastfeeding? Okay, if you're breastfeeding, or can you pump and, like, leave some milk so that your partner can, like, feed the baby during your off shift, those 4 to 6 hours. So, I talk very specifically about sleep and engage family structure, like family system support systems around that. Another time where it's very, very important to engage family is for patients who carry a diagnosis of bipolar disorder.
Mhm.
Patients who carry a diagnosis of bipolar disorder are at high risk for postpartum psychosis, which is a psychiatric emergency and needs to like have basically inpatient admission. So you need to be able to know and like know the criteria and what that looks like. But postpartum psychosis in general is pretty rare, like maybe 1 out of every 1,000 births. But for folks who carry a diagnosis of bipolar disorder, they are much higher. I want to say it's like 23 times more at risk for postpartum psychosis. So it's at some point during the pregnancy period, I have a session where it's like solely focused on education around what is postpartum psychosis, what does it look like, how do we prevent it, right? What are the things that obviously I'm not hoping that postpartum psychosis happens, but what are the bumpers that we can put in place to kind of protect you from kind of having this experience? And if you do have this experience, what do we do? What does the treatment look like? What are the supports that you need to like kind of immediately activate? So I do kind of the thing about postpartum psychosis is that the person experiencing it may not have insight or understanding as to what is happening. So it's really important that their ecosystem or the people around them know what the signs are, know what the symptoms are, so that they can be the ones who can activate help. So that's another point in time where I think it's really important to like bring in the other players on the team.
And I have one more question about that because you bring up a really important, like top part of the conversation, and sort of like maybe like the idea of maybe that crises that may come up potentially. And so, just one question about this is, what do providers do if they have a mom or a person who's given birth who is experiencing thoughts about, ending their life, suicidal thoughts, or potentially even thoughts about harming their child, which I know is very scary for many people.
Yeah.
Either of you, or you guys can piggyback, but just a little bit about that.
I'll jump in really quick. I mean, I think it's similar to how you might treat or how you might respond to any person who's reported some form of suicidal ideation or suicidal risk. So doing a very thorough risk assessment, looking at both the risk, but also the protective factors, doing all the traditional pieces in terms of safety planning, increasing sessions, seeking out support from a psychiatrist, looking for other forms of social support, again, looking closer at who is available to you, who do you have access to alleviate some of the stressors that are present for you in that moment, making referrals to the suicide hotline, really focused in interventions around emotional regulation or distress tolerance, using kind of some of the DBT interventions to help to improve a sense of safety. But again, like when we think about people who have either just had a baby or are currently pregnant, to do that work of really looking more specific of who you're working with, of are there those thoughts of harming the baby, and making room for that to be named, but really also looking from the lens of intention, both in terms of suicidality, but also in terms of any harm towards the baby, and really kind of gaining clarity there. And again, doing all the work to support that person who may have ideation alone. But again, when we pair the intent and the plan and all of those pieces, that would then warrant hospitalization. But yes, I think those are important ways in which we can both identify and assess risk, as well as support someone who's going through that. You can add anything more, Dr. O?
Yeah. So, like, circling back to postpartum psychosis, I think one of the reasons it is such a big deal, like it is a psychiatric emergency, is because there is a high risk of like suicide, during if someone's having an episode, and also infanticide. So that's why it's like a psychiatric, emergency. I think screen, like Dr. Dom said, screening for risk. I always ask moms like, "Oh, are you having any sort of like aggressive thoughts towards baby, or any strange thoughts towards baby as well?" And I think it's also important to point out that most moms, the lion's share of moms, have intrusive thoughts postpartum. That is it's kind of like a hormonal thing, right? Most women have intrusive thoughts postpartum. It is important for you to understand what those intrusive thoughts are, what the nature of them are. Again, it goes back to what Dr. Dom was saying about rapport and making the patient feel safe and secure in that relationship that they have with you in the therapy space. Because sometimes, again, this kind of goes back to postpartum OCD, for example. Somebody might have intrusive thoughts and then develop compulsive behaviors, around that. Sometimes people just have intrusive thoughts and like, oh my God, why am I thinking these terrible things about my baby? Right. These things all exist on a spectrum. I tell my moms like, oh my gosh, if you have like intrusive thoughts about you see your newborn like rolling down the stairs, that my next question is like, okay, like what is the behavior that follows that? Does that make you take off your socks before you go down the stairs and you hold the railing? Right. It's kind of like an adaptation. Again, like I said, you have anxiety for two people now.
Anxiety.
It's like thinking about all the possible negative things that could happen. And then you're strategizing, how do I prevent this harm? But it then becomes pathological. It then becomes impairing, right? If you have intrusive thoughts of baby falling down the stairs, and you're like, oh my God, I can never take the baby down the stairs. And then you never take because obviously that gets in the way of you to be able to like move through your life. So it's like, okay, what is the intrusive thought? What is the nature of it? And what do you do about it? Right? If you're having an intrusive thought and you're like, oh, this sounds like a good idea, that is concerning, right? That is more of like a psychotic process. If you have an intrusive thought and it makes you take a protective action in a way that's not harmful, right, to you or to the baby, or it's not functionally impairing, that is also something to monitor, but also okay, right? If you think your baby is, contaminated with germs and then you're starting to give the baby a bath 20 times a day, that's obviously harmful to the baby. So again, that is where we're assessing for impairment. So intrusive thoughts can be also something that is important to kind of understand the spectrum of how that presents, do some education around the normalization of it, but then also what is the impact of the intrusive thought? I think that's where some of like the clinical skill and the nuance kind of comes in terms of teasing apart.
I could talk to you all day, and because this is really important information. And I'm also trying to be the timekeeper here. So I'm going to land the plane. But I think what might be helpful is because you guys shared so much valuable information, people are probably wondering, like, where can I get more of this? So let me ask you, what can providers do to increase their competence in providing maternal mental health services and treating perinatal disorders? Where do we go for more? Dr. Dom?
Yeah, just real quick. I have fallen in love with the Perinatal Support International website and all the resources they have there. So there are quite a number of free webinars that you can just like click on and watch at your leisure. They also have some certifications that you can go through training to become a certified professional and providing care in that way. Another resource that I have found is the Institute for Perinatal Quality Improvement, and particularly this branch that they have around Speak Up Against Racism Action Pathway. And so their organization is really a good tool for providers on, both medical OB, but also, therapists and otherwise psychiatrists that you can do some work to assess your bias, but also gain more insight and awareness of the inequalities within the healthcare system. Ultimately, their mission is to reduce perinatal mental health disparities. And so that's another great resource.
Some resources that I guess before I share resources, I like to like take a step back and just again emphasize how like while this is a niche area, like maternal mental health, perinatal mental health is like it's a niche. When you take a step back, it is a huge, huge body of knowledge, right? There's so much from preconception to like the toddler years, right? Postpartum. You have issues of infertility. That is a whole specialty on its own. You have issues of pregnancy loss, miscarriage. Even within the world of pregnancy loss, right? You have miscarriage, you have stillbirth, you have termination for medical reasons. Each of those things is like a whole situation, right? That there can be expertise developed around. You can have like, pregnancy specific, you can have like postpartum specific, and you can even specialize in like postpartum anxiety or specialize in postpartum OCD. And so I would say when you're seeking out training and resources, these trainings are just your entree to the field. Going and taking a seminar or a weekend training or whatever doesn't make you an expert, but it opens the gate, right? You still have to develop the knowledge and the skill and like the competence and continuously educate yourself around these topics. And so there are organizations like, for example, Resolve is one that like focuses on infertility. There's the American Society for Reproductive Medicine. They have like a whole mental health like subgroup under that, and they have entire, I think it's like a year long, maybe like training program that you could like self-pace, that you can really specialize in like what it means to go through IVF, like what it means to go through like surrogacy, what it means to like have like a journey that doesn't look like the typical, pregnancy. There are organizations that focus on, pregnancy loss. One of the perinatal organizations I like is called the Marseille Society. So the Marseille Society is like an international perinatal mental health organization, but the North American chapter is called the Marseille of North America, MONA. They have conferences and they have like workshops and like trainings and things like that as well. So whatever your whatever your interest is in within the world of like perinatal mental health, you can do a deep dive on that. Sometimes people who only know a little bit can be quick. It's a dodge in medicine. Like people who know a little bit can like be like dangerous because you don't know what you don't know, right? And so if you are interested in this field, my advice is to pick one thing, do a deep dive on that. Really get that 10,000 hours of mastery under your belt. It's not to say that you can't take on patients or you can't take on clients during that time of mastery, but continuously immerse yourself, continuously learn, do focus study around that, and then build from there. Because it can easily get overwhelming when you go to a conference and there's like 12,000 topics like presented, because there are 12,000 topics underneath the umbrella of perinatal mental health. So just take your time, right? Build expertise and just kind of like build on one layer at a time. And I think that's how we end up doing our patients, like bringing really quality care and expertise and depth to the care that we're bringing to our patients.
Thank you all so much. If people want to keep in touch with you, or maybe, if either of you are accepting clients or patients or referrals, or if providers want like to call you or something like that, to consult, is there a way for them to contact you or to kind of see some of your work?
Yeah, the best way to be in contact with me is through the Black Girl Doctor. So you can go to our website, theblackgirldoctor.com. You can also connect with me on social media. So on Instagram, I am at @I am_Dr. Dom. And then I have a website called the sandwichgenpsych.com as well.
And for me, you can find me on my website, jenniferokwerukwu.md.com. I'm sure I can share that in the resources. And you can also find me on social media as well. It's Dr. Jennifer_O. Yeah, those are the best ways to reach out to me.
Thank you both for spending so much time talking with us today. I think a lot of providers will get a lot of valuable information to start their journey and to learning more about this very vast topic of maternal mental health. So thank you all.
Thank you. It was a pleasure being here.
Yes,
thank you so much.